Okay, so we're finishing up with sedation and paralytics, and we've talked about sedation a little bit with the what bundle? The ABCDF bundle. That bundle kind of fits into the ABCDF bundle a little bit, right? The whole goal of the ABCDF bundle is to get people off the ventilator, and if you're off the ventilator, you don't get a VAP, right? But now we're talking about the C, the choice of sedation here, right? So the letter C is part of an ABCDF bundle to get people out of uh, out of the side effects that could happen, out of the consequences that can happen from the choice of sedation. Right? Certain sedation medications can cause delirium independently of other ones. Right? Sedation in general can cause delirium, but there's certain class of medications that can cause delirium all the time. Which one is that? Which class of sedation can cause delirium? Benzos, right? So benzos up here cause delirium directly, right? And D was one of our bundles as well, right? So we want to avoid delirium in the first place. Then maybe we can avoid sedation, right? Because we know sedation does cause it, but sleep deprivation could cause delirium, right? Neurological diagnoses, of course, but there's other medical comorbidities, other things that contribute to delirium, which we'll focus on a little bit more in neuro as far as the types of delirium, how to assess delirium. We talked about how to assess delirium in pulmonary, but we'll get a little more deep into that, right? Withdrawing from medications, right? Withdrawing ironically from benzos can cause you to be delirious. Withdrawing from opiates can cause you to be delirious, right? So we're trying to look for these different reasons why we have delirium, right? And sedation can help a little bit with delirium, but we want to choose the right sedation, right? So sometimes someone might have pancreatitis, and which medication might be contraindicated in pancreatitis, which sedation medication? Propofol is contraindicated in pancreatitis, right? And we know that pain is a key element to delirium, so that's why A was our assessing pain, right? Making sure that we are fixing pain before we even choose sedation in the first place. That's why it's first, right? So we're avoiding the need for sedation altogether, right? And then agitation, agitation can happen from like withdrawals, for instance. It can happen from just straight up anxiety, whether they have it beforehand or they developed here in the hospital. Right? They're restrained. All these things that are interlaced cause the three different elements of pain, agitation, and delirium. And pain, agitation, delirium, as you notice, are all interrelated as well. They all cause each other and potentiate each other. So we have to, stop it somewhere. And sedation can help, right? First, of course, pain medication is our go-to, but we need to be able to assess these things, and also we need to be able to halt it with sedation medications, right? So that's what we're talking about today is sedation, a little bit of pain management. The best sedatives are which kind of sedatives? The sedatives, no sedatives, yeah, but sometimes you need it, right? And the sedatives you need are ones that are called analgo sedatives, right? So analgo sedatives. And those are ones that cover sedation and pain, the pain being the analgesia, right? So those are the best ones, right? So we'll talk about those ones. Those are the ones you want to identify. Say, hey, can we start this one? It'll control their pain and it will control their sedation. Right? And then we'll finish off with paralytics, right? And how to monitor paralytics and what the paralytics are, which are the best ones, not acetylcholine basically. And those are the ones that we're going to give to our patients and we have to monitor for side effects, right? So we'll get a little bit of deep dive on these guys here. All right, so sedation needs. Why would you need sedation? All right, so we need to assess, do they need sedation for a pathological reason? Do they have are they actually desaturating? Meaning their sats are less than what? 88%, right? Their stats like 91%. We can work with that. We can manipulate some things. We can figure it out. Not it's worrisome, but not to the point when it starts desaturating to less than 88%. It's 82%. So well, shoot, I need some sedation to get this patient oxygenating well, right? Because we know that sedation is going to lower the oxygen demand of the tissues, our VO2, and therefore we can deliver more oxygen if we are to, if we can, our oxygen utilization will be improved if we give sedation, right? And the only reason why we know someone needs that is if they start to desaturate, right? And ventilator dysynchrony, they're not getting the volumes they need, they're not getting the oxygen or PEEP they need. This ventilator dysynchrony is a reason for sedation as well, right? And then seizures. So if someone's seizing, they need sedation, right? And we be on a sedation that is anti-seizure or anti-epileptic. So you can't just give any seizure medication, any sedation medication, because not all of them have seizure properties or anti-seizure properties, I should say. Okay, an elevated ICP. So someone's ICP is elevated, greater than 18, greater than 22 technically. That's really where they start needing sedation to control their ICP. It's going to reduce the basal metabolic rate of the brain, or the brain's metabolic rate. Just like we've reduced the metabolic rate of our tissues, our VO2, we can reduce the VO2 of the brain. And therefore the brain requires less oxygen, and that way it doesn't get the consequences of low oxygen states, which we'll talk about in ICP. And neuro, okay? And then paralytics. So sometimes you just need to, cut the ICP down. You need to fix the ventilator synchrony. So paralytics are not going to fix seizures, but paralytics can reduce your ICP. Paralytics can reduce your tissue's oxygen need. Okay, so as we mentioned, we want to treat pain first because pain is what's going to be integral to causing delirium, agitation. And if we know that sedation can be used for agitation, sedation can sometimes be used for delirium if it's getting out of control, right? But sedation is not going to fix pain unless it's a analgesic sedative, then it's like a 2-for-1. So we do want to treat pain first, right? So pain medication or pain infusion or pain analgesia infusion would be something we would choose, right? And usually we have a little ladder system or a multimodal pain management system where we start little, different steps, right? So first we just start out with Tylenol. And everyone's like, oh, Tylenol's not going to work. Well, it actually does work wonders. It does a lot of good stuff, right? So we do multimodal pain management, and then we can start increasing sedatives, right? Sedatives to improve ventilator synchrony, sedatives to fix things that we can't fix with pain control, right? So we try pain control first, and then if that doesn't work, we then add sedatives, right? So treat pain first because why? Sedation, just any sedation in general, even the best sedation ever, like Precedex, like, oh, it's the best sedation ever. That one can also increase mortality, make more patients die for those that don't get it, right? Because Precedex itself has side effects, but also there are consequences of giving any medication to a patient. So if we can avoid the medications, great, right? There's all kinds of non-pharmacological things we can do to fix pain, to fix delirium as well, right? Because we know delirium is integral to causing pain, right? And causing agitation. So we can fix those, then we are able to stop this cycle, this vicious cycle from progressing. Okay, so when you have more sedation, increases your vent days, increases your days in the ICU, and increases your days in the hospital. And both of those things independently can increase your mortality. Right, so we want to make sure that we are avoiding sedation if it's not needed. Right, so we have to assess if sedation is needed. And how do you do that? SAT is going to get them off the sedation temporarily, and if they fail that SAT, then you can restart at half the previous rate. So that way you're at least cutting it by half every 12 hours. But we have some objective endpoints. We have RAS scores, right? So the Richmond Agitation Sedation Scale assesses how much sedation someone needs, right? If you're giving 30 of propofol to someone, that could be creating a RAS of 0 or a RAS of -4. Which one's worse? RAS -4. You might need the RAS -4 with an asterisk if you have ventilator synchrony, you have seizure activity, you have elevated ICPs. Then it's valid for you to have a deeper RAS or a more sedated patient. But other than that, there is no real reason to have someone on sedation. All right. So we've got to be alert to that, and using the RAS score can help us identify if someone's appropriate or not. Right. So the goal RAS for everybody should be what? 0 to -1. All right, 0 to -1, and we'll talk about the RAS score in more detail. All right, so too much sedation can lead to hypotension. Every sedative ever causes hypotension. Right, ketamine can maybe raise your blood pressure a little bit, but it does have some hypotensive properties. And then we start giving pressors, and we start giving it peripherally, and then you can't get a central line, and then your pressors go up. So oftentimes you'll get a patient from an ED or a patient that just got intubated. And usually if you're intubating someone, you would have pressors on standby to begin with, because we know the intubation itself can lower the blood pressure, but also sedation that we give during intubation can lower the blood pressure. But sometimes we'll get patients on 4 mics of Levophed and 2 mics of fentanyl and 50 mics of propofol. It's like, well, shoot, I know what's causing the low blood pressure, right? That's not a septic shock that's brewing or a cardiogenic shock. That's what kind of shock? A neurogenic shock, right? Or it's iatrogenic. It's something we caused, right? And then sedation vacations. So sedation vacations are done to get patients off of sedation, right? So we have to have some line in the sand. It's like, well, 8 o'clock every day, twice a day, right? 8 a.m., 8 p.m. We're going to cut the sedation off completely, cold turkey, 100%. You're taking it off. And as we know from our respiratory lecture, there is safety screens. You're not just like, oh, Aaron told me I took off the sedation. Look at my patient, right? No, there's the safety screens that we go through to make sure that it is safe to take a patient off sedation, right? Same thing, if they pass that trial, then they can then do an SBT. But the SAT was focused on getting someone off sedation, right? So that way at least someone's doing it, right? Someone's taking them off completely. And then if they don't tolerate it, then we can go ahead and restart it at half the previous rate, right? So if it's 50 of propofol, we can restart at 25 mics, right? And then now we have a new starting point. And they might have to go up to 30, 35, 40, but we can actively throughout our shift keep titrating to a goal objective endpoint, right? A RAS of 0 to -1. Okay, and then sedation should not be given if someone has pain, anxiety, agitation, sleeplessness, right? So you see it given for these reasons, but it's not, a lot of our set of medications are not anxiolytic. They are not medications that are going to fix pain. Some do, and those are great ones, right? So there's a little asterisk on pain, like dexmedetomidine or Precedex. It has some pain management properties. Ketamine has some pain management properties as well, but both of those primary function is for sedation. Okay, so what else? So sleeplessness. So someone's not getting sleep. I'm going to get some sedation, let them sleep tonight. It does not cause REM sleep. There is not a single sedative that causes REM sleep. It's not possible, right? They are all validated that they do provide a reduction in wakefulness, right? It inhibits the reticular activating system in the brain, but it doesn't cause you to have REM sleep. They're not going to get more restful once they have sedation on board, right? It's like their eyes are closed, they're sleeping. Well, that's not true, right? They literally are not getting the restorative sleep that's required, right? So the best way to get restorative sleep is to let them sleep without sedation, okay? So that's the idea with that. Okay, so what else? So we're doing our SAT daily. And what about non-benzos and benzos? So as we know, benzos or non-benzos or regular sedative medications cause complications of increased ICU days, increased hospital days, delirium, etc. But benzos independently, just by themselves, if you give benzos, they're going to cause a increase in delirium and an increase in mortality and such, right? So the benefit of not using benzos is you have decreased mortality, decreased ICU days, and earlier extubation. Benzos like to accumulate in tissues, right? They like to accumulate in fat tissues as well, right? And we know America's a little bit more on the Rubenesque side of paintings, right? They have a lot more fat tissue to give. Yes?
The restarting at 50%, does that take into account the minimum starts? Or
no, we have a good point. So it's per protocol. That's our protocol. So if you, for instance, you have 25 mics, right, of propofol, and you cut it off to 0, and they failed. They're getting RAS negative plus or RAS plus 3, failing to synchrony everything. They're starting DSAT, tachypneic, tachycardic. They went to VTAC. They had some like AFib RVRs. Well, shoot, today wasn't the day, was it, sir? Right. So then you restart it back at half the previous rate, which is what? 12.5, right? And that's your new starting rate, 12.5, and now you're going up by 5s, right? Yeah, if you like the next 8 p.m. is 12.5, and then you go down to 8.125 or something crazy. But that's the only reason why you come on shift and you're like, why am I at this weird rate of 17.5 or 22.5? It was because someone did a sedation vacation at half the previous rate, right?
Okay, so they it was a 5, and then we shut it off.
You'd restart at 2.5.
Even though that's below the minimum.
Correct.
Okay, gotcha.
Yes. All right, so yeah, and then sometimes we can have some foresight and say I'm going to be at 20 mics, and then if I restarted back at 10, right? Just it'll check a box somewhere in an ICU nurse's brain that we're not at 0.5s. Okay. All right, so BIS and RAS. So these are the objective endpoints that we can use to monitor if someone is getting enough sedation or not. All right, so RAS we know is 0, -1. BIS might be a little bit new, right? So BIS is bispectral index, and we'll point this out when we look at paralytics. And you only use it when you're on paralytics, right? If you're on paralytics, do paralytics cause sedation? No, all they do is relax the skeletal muscles, right? So if you have someone on paralytics, how do you know they're sedated? You don't. It's like, well, I started at 20 when they went in and they were sedated. Well, we know that certain medications wear off over time. They develop what's called tachyphylaxis, right? Where the increasing doses of medications to dose 1 causes a great response. Dose 2, less response. Dose 3, less response, right? So let's imagine that's like 2 mics of fentanyl every 12 hours, right? So 2 mics at 8 o'clock, well, great response. Look at that. They're well sedated, pain's well under control. And then 2 mics at 8 p.m., it's not as great, right? 8 a.m. the next day, it's not as great as well. It keeps going down over time. The efficacy of the medication deteriorates with time with usage of that medication, right? And that is different from tolerance, where they require increasing doses. This was just 2 mics, 2 mics, 2 mics the whole time, right? Whereas tolerance is where they require 4 morphine and now they require 8 of morphine to get the same pain control. It's a little bit different, right? So BIS is, you can't say, oh, they're fentanyl 2 mics when they went in. How do I know if after day 3 of paralytic infusion if they are well sedated or not? They could be awake and alert. We don't know, right? So that's where BIS comes in. It averages EEGs and looks at to see if they have a good reduction in EEG activity or they're at an awake level, right? And it's a scale of 0 to 100%, and we'll look at that, right? Usually you want to goal about 40 to 60% on your BIS for someone that has that's on NMBAs. And what are NMBAs? Neuromuscular blockade agents, right? 60%. That's usually our goal BIS. Whereas RAS is 0, -1. That's where everything should start at, and sometimes we can make it a little bit less if we need to, right? Or I should say deeper if we need to, like a RAS -3 or -4. Okay, tachyphylaxis we talked about. That's an increasing doses of the same medication, right? So you have dose 1, dose 2, dose 3, and they have less effect each time, right? Whereas tolerance is more of a physiological change. The patient develops more receptors or less receptors for medication. Okay, so 10 tips. We talked about this in respiratory, but prioritize pain management. That's our goal first, is assess pain first and fix pain. And if the pain is good, right, then we know that or if the pain has been controlled or been managed, then should start giving sedation. Okay, avoid benzos, as we mentioned, right? Remove plastic. We know plastic causes delirium, right? So ventral dysynchrony, plastic should be on here as well, right? Being hungry, being dehydrated, vascular access, endotracheal tube, these cause pain, and they can also cause delirium as well, right? And cause you to be agitated as you have restraints in place, right? So we want to avoid, physical things and plastic things if we have to, but there are some reasons where we need to use these items. All right, so do you have an indication for sedation? Yes or no, right? If there's no indication, right, my patient is, their event settings look great and they're not super agitated. They don't have a diagnosis that tells me I need to have a lot of sedation, such as, increase in ICP or seizure activity. I think it might be okay to go ahead and start weaning, right? Every 12 hours, we're going to start doing a sedation vacation, but also we're going to assess for delirium because we know delirium can increase my sedation needs, right? And how do I know if someone is adequately sedated again? I'm assessing the what? I'm assessing the pain, but also I'm assessing RAS, right? So those things are going to let me know if I need to, fix pain first, or if I'm too deeply sedated. Okay, going back to the other side, we have status epilepticus, we have ICP, we have severe respiratory failure, and like a PF ratio is really poor in high vent settings. Well, then we need to assess, and treat pain first, and then after that doesn't work, we can then go deeper on our sedation, just like before, right? And assess our BIS if we're using NMBAs, which would be used for high ICPs or high vent requirements, right? And then we have, you got 2 types of delirium. We got hypo and hyperactive, and we'll talk about those in neuro, right? Most common is hyperactive, where they're super agitated and they're pulling at their lines and tubes, right? They might be swinging at you and kicking, and they're not normally like that. They're not normally a violent person. That patient probably needs some more sedation, right? And of course, that was after we did pain control. Okay, and how do we know they were this? We use the CAM ICU to assess if they are delirious or not delirious, right? If they have hypoactive delirium or hyperactive delirium, and we'll talk about that. Okay, and of course we're assessing to 0, -1, and we're always controlling pain and controlling their sedative needs if need be. All right, if at any point they do develop seizure activity or they do develop ventilator dysynchrony or do develop the need for paralytics, then of course we we provide the sedation as needed. Okay. So yeah, tachyphylaxis, just going back to why is Albert Einstein here, it's because that's where you keep using the same dose and expecting the same result every time. That's the definition of insanity. And Albert Einstein never said that. That's not something he ever said in his lifetime. All right, so sedation management. So how do you manage sedation? All right, so we interrupt it every 12 hours for an SAT. And if they don't meet the criteria for SAT pass, then we're going to go ahead and restart at half the previous dose, right? So if we're at 30 mics, we're going to restart at 15 mics, right? And this is cold turkey. It's not like 30, 25, 20, 15 every 5 minutes up until 8 o'clock. No, it's at, you get a report at 7:15, 7:20 the latest, and your propofol's at 30 mics, right? And then you're going to go ahead at 8 o'clock, bam, it's going to 0, right? As long as they met criteria, right? They have to have the SAT pass. They have to pass the SAT screen, okay? And then low vent settings, right? That doesn't require continuous sedation, as we mentioned in mobility, right? So everybody's RAS 0 -1, but who really needs sedation are those that have more than 60% FiO2, more than a PEEP of 5, right? PEEP of 8 even, right? Those patients, yeah, they probably need some sedation for ventilator synchrony. But if they're less than that, why are you on continuous sedation? If you get propofol at 30 mics and you see your patient is on 35% and PEEP of 5, it's like, why do we have continuous sedation going on? What's the goal here, right? Are they really kicking you? Are they super agitated? And you don't see an ICP in place, and you don't see paralytics, right? So and you wouldn't have paralytics for that low settings anyways. But what's going on? Why do we need this, right? Sometimes we do get on autopilot, and that's not something we want to do because we know each one of these sedatives can increase the mortality, ICU days, etc. Right? So we want to, try to get them off IV sedation. Does that mean remove sedation altogether? We have other things we can do. We have PO sedation we can do, right? We can have PO agents like antipsychotics and such for someone who's super agitated. Okay, and of course for someone has alcohol withdrawal, right? We don't always need IV Ativan infusion. We can give PO chlordiazepoxide or Librium, right? We can give barbiturates, which are not benzos, to control alcohol withdrawal. Okay, so we titrate to 0 -1. And then in the meantime, we're going to give IV pushes. Usually always the stepwise approach is use POs, then IV pushes, then an IV drip, right? Sometimes we just go straight to an IV drip, and sometimes you need to, like if someone's given rocuronium during intubation, we know that that's going to get them paralyzed for about 30 to 45 minutes. So we have to start something IV. And then we'll start titrating down as need be, right? Everything is titrated to a objective parameter that everybody knows how it works, right? Everybody knows what a RAS of 0 to -1 means in this ICU. Everybody knows what a train of 4 to -2 means in this ICU. Everybody knows what a CPOT of 3 or less means, right? So everything has an objective endpoint, right? So our default RAS is 0 -1. Why would you have something deeper, like -2, 3, 4, -5? That would be someone who has increased ICP, actively seizing patients, right? Someone who's getting paralyzed, right? That'd be like our rocuronium post-intubation, right? They're not oxygenating, so their stats start dipping, right? That'd be someone that needs to be on more sedation, all right? And RAS is objective, right? Someone otherwise in the past, they said, oh, they're obtunded. And someone said, oh, they're lethargic. And someone said, oh, they're somnolent. And someone said, oh, they're semi-comatose. So it's, oh, no, they're comatose, not semi-comatose. Where'd you go to school at, right? So that's very, very subjective. There's no, how do you know that that's gonna have the same meaning to each person with every different background, right? So the RAS scale is an objective number of how sedated someone is. Are they -1 or -2? I know exactly what the difference is. Do they look at me for more than 10 seconds or less than 10 seconds, right? Which one is if they look at me for less than 10 seconds? Like look at me in the eyes for less than 10 seconds. Right, less than 10 seconds is a -2, right? That means they open their eyes to voice. All right, I didn't touch them at all. All I did was call their name and I said, look at me in the eyes, and I'm going to count to 10, right? And they do it for more than 10 seconds. They're like, why'd you wake me up? Right, that would be a patient that is a -1. Right, you just walk in the room, you don't require voice at all, right? That's just that's a 0. They're alert and calm, right? You might have, then of course you want them to look in your eyes to make sure they're just not like a vegetative state looking up, right? All right, so then what sedation can continue after you get extubated? So that's Precedex or dexmedetomidine, right? Basically something that's not a narcotic. Right? Narcotic means sleepy, right? So it's narcolepsy, is sleeping all the time. So a narcotic is something that causes respiratory depression, technically, right? And yeah, sometimes the DEA has a different definition of narcotics, but as far as narcotics, as far as the pharmacy definition, it's something that makes you sleepy. Right? And yes, there's Schedule 1 drugs and Schedule 2 drugs, et cetera, but we're saying anything that makes you cause respiratory depression, that's something I don't want to have on someone who just got freshly off a ventilator, right? I want to put them back to the ventilator because they stopped breathing, right? So dexmedetomidine or Precedex is our great agent for that reason because it can be used after extubation. If someone is getting a little squirrely, it's like, I'm going to take the tube out. Hopefully that makes you less squirrely, and then maybe 6 hours later, we can then take the Precedex off, right? So it's like a glass of red wine. It's like a glass of, of smoke, right? That's your Precedex right there. That's what's going to help out your nerves, right? It's non-respiratory depressant, right? Ketamine can depress your respirations, but there's some protocols, not here, where they can use ketamine to get people off, get off the ventilator through procedures, conscious sedation and such, right? And then physical management of sedation. So how do you physically manage sedation? How do you not giving free samples at Costco? It's like, hey, your loved one's getting propofol. Do you want some propofol too? Right? Your loved one's getting fentanyl. If fentanyl sells well in the streets, do you want fentanyl too? Right? So we have little lock boxes. Little lock boxes here. They're clear, so we can see if the fluid's running low. Right? We can see if there's a reason for, if there's a need for spiking of the bag, for instance. A good practice is to have another bag behind your bag, so that way it's ready to go, like pressors and such. Right? Fentanyl is kind of frowned upon because you don't want that in there for 2 hours because they track it downstairs. They want you to spike the fentanyl within 15 minutes of pulling it from the Pyxis. But either way, we have another propofol in there, or we have another ketamine in there ready to go. Okay, but we don't want them just yoinking the fentanyl bags like, oh, where'd my fentanyl go? I was being a good nurse, making sure my bag didn't run dry, and your whole bag, 250 mics or 2,500 mics of fentanyl is gone, right? So now one just scored off with fentanyl. So how do you prevent the free samples? Well, we use little lock boxes, right? Little lock boxes are punched in, right? That's going to prevent the bag from being tampered with. But what about taking little free samples off the ports here, right? You got a little port here, port there, port there. We got like 4 or 5 ports where we can pull in little samples. It's like, well, they don't have syringes. I bet you every single room right now has syringes in it, right? Has 10 cc's even, right? They can figure out how to empty a flush syringe. They've seen you do it all the time, and use holy water on their loved one all the time, right? Going everywhere, right? So that's we have little sample ports for these, and if they don't, we have needles in the room too, right? We have blunt needles, we have maybe sub-Q needles, but definitely have some blunt needles and flushes in our rooms that we can use to pull out samples, right? The ideal thing is to use this narcotic tubing, right? So the narcotic tubing is different than the regular standard IV tubing or primary IV tubing. So the primary IV tubing has all the little sample ports on it, whereas a narcotic tubing has no port for secondaries. So that's going to avoid errors to begin with, because that can happen where someone, a nursing student or otherwise, can hook up a Zosyn to the propofol. It's like, whoops, that's the wrong one. All right, so that you want that to happen, but also it has no sample ports all the way down. It doesn't even really have that one either, and that's a error from the manufacturer. But there, if you look at it has little nubs there where it doesn't have anything that you can hook up a syringe to. Okay, and then a little pro tip is to use a Y tip or Y splitter at the end, because oftentimes it doesn't aspirate well, and sometimes you need to have like 2 sedatives, like a fentanyl and propofol going, so you can then put it the same lumen at that point, right? All right, so then what else? So we want patients visiting, but we don't want them getting free samples. And you can lock the Alaris pump, right? Lock the Alaris pump. You can lock it. These are the instructions how to lock it. Basically, a little black nub on the back that you hold and press for about 4 seconds, and it will lock the pump for you, right? You got to be coy about it, right? You're not going to be going up and like behind it. It's like, I know there's a button back here somewhere. You're talking out loud to the family, right? And say, there it is. I found it. And you bring someone in, and like they're like, oh yeah, there it is. And let's mark it with a label next time, right? So you want to be a little coy about it, right? You just want to go up there as you talk to the family. You can hold it for 4 seconds, and you hear beep, and then you'll be able to then have that pump locked, so they're not giving their loved one, that nurse doesn't give my loved one enough fentanyl, or they should be going up on that white stuff, right? So they can sleep more, right? So we know that that's not going to help, but also we should be in charge of what's being infused in our patients, not the patients, right? Or the family, right? We do have some adventurous patients who give themselves little boluses here and there, right? We have RNs as patients sometimes too. All right, they'll like cancel the alarms for us. I just cancel the alarms. Like, just don't push it at all. I don't trust you, right? So I push the alarm, but I also give myself a bolus. All right, so yeah, so make sure you're locking the pump and you're locking the drips, right? And we're using narcotic tubing so that we avoid the issue of anybody taking samples